Dr. Ken Landau. Thanks for watching. Let's talk about a condition known as functional dyspepsia. Functional dyspepsia is a condition that affects the gut in a significant number of people. And it's estimated to affect anywhere between 20, 30, 40% of the population. So we have a question right away to start. Is it a real disease, or is it just a variation of normal? Well, there are two distinct subsets of functional dyspepsia. So one of them is postprandial distress syndrome. It affects about 12% of the population at least. And it relates to being full after you've eaten just a little bit, so you can't finish a normal-sized meal. That's kind of subjective, don't you think? And then we have the epigastric pain syndrome. That affects at least 5% of the population. It's epigastric pain and burning sort of at the pit of the stomach, but it's not the burning that radiates up behind the breastbone. It's not the same kind of problem you would get with gastroesophageal reflux, but the two could be combined. And the symptoms, even after a complete workup, tend not to find anything wrong. Actually, most people who have the condition don't even go to a doctor, don't even think they're sick. Well, if it's enough to be bothersome, and if for the postprandial dyspepsia, you can't finish a normal-sized meal at least 3 times a week, or for the epigastric pain syndrome, you have pain, not necessarily related to the meal, at least once a week, then you might have functional dyspepsia. Functional dyspepsia, extraordinarily common. It's considered a meal-related syndrome. 80% of the people report that somewhere between 15 and 45 minutes after they eat, they develop the symptoms. Seems to affect anywhere between 10% and 40% of the U.S. population, basically the same in Asia. Seems to affect women somewhat more than men. It's somehow related to irritable bowel syndrome. Actually, the incidence of functional dyspepsia and irritable bowel syndrome is equal. And as a matter of fact, a significant number of people have both symptoms of irritable bowel and functional dyspepsia. Well, again, it calls into question whether we're dealing with a disease or a variation of normal. And there's an overlap not only between the functional dyspepsia and the irritable bowel syndrome, but people who have either of those conditions or both are more likely to have other somatic disorders that are not related to the intestines. So fibromyalgia, overactive bladder, chronic pelvic pain, much more common in these individuals. So it might be that they're just predisposed to have symptoms, and the symptoms don't really have anything to do with the gut at all. Well, functional dyspepsia supposedly is related to abnormal visceral sensations. So you get some indigestion, some belching, some burping, and some fullness, and the bloating, and the nausea, stomach pain or discomfort, inability to finish the normal-sized meal. You're often diagnosed as having gastritis or psychosomatic condition. Well, we know there are certain risk factors that seem to trigger both the irritable bowel syndrome and functional dyspepsia. And those risk factors are gastrointestinal infection, traveler's diarrhea, taking an antibiotic, taking a non-steroidal anti-inflammatory drug, or smoking cigarettes, being overweight or obese, or suffering from perceived stress or psychosocial problems, anxiety or depression, childhood abuse. Those are the regular factors that we call out for almost any medical condition. And now we're starting to say, well, it probably has something to do with abnormal bacteria in the gut. And it might be an abnormality of that gut-brain axis because of disturbed microbiome. Well, the symptoms that you suffer don't differentiate an organic disease from a functional disease. So you could have gastroesophageal reflux disease without esophagitis. You get that retrosternal burning pain. You get some acid feeling in the mouth. That's part of the whole syndrome. You could have irritable bowel syndrome. Irritable bowel syndrome, it's associated with some kind of change in your bowel habits or the stool form or consistency. And that's not present in functional dyspepsia. Over the past years, it's gone through some changes as far as terminology. You used to call it non-ulcer dyspepsia or irritable stomach syndrome, chronic idiopathic dyspepsia, then it was ulcer-like syndrome or reflux-like syndrome or dysmotility-like, because you go to the doctor and it's often diagnosed as gastroesophageal reflux, and right away you get some pills for your supposed reflux. And you take them, it doesn't get any better. You say, hey, the medicine didn't work. Well, you didn't have the diagnosis. You have functional dyspepsia oftentimes. And the symptoms aren't necessarily present all of the time. They come and they go, they come and they go. As I mentioned, it's more common in women than men, but there's a less prominent sex differential than there is in irritable bowel syndrome. Irritable bowel syndrome, a lot more women. Here, functional dyspepsia, somewhat more women. Well, we rule out any kind of structural abnormality. So in those people who are sick enough or symptomatic enough to go see the doctor, rule out peptic ulcer disease, rule out Helicobacter pylori. That's a bacteria that's associated with gastritis and with peptic ulcers, stomach ulcers, duodenal ulcers, and sometimes gastric cancer. So we exclude heartburn and symptoms like that. But overwhelmingly, people who have functional dyspepsia, symptoms of functional dyspepsia, can't find anything wrong with them. In the 5% or so who have the diagnosis of Helicobacter pylori infection in the stomach, treat it 90% of the time. The symptoms of functional dyspepsia don't go away. Seems like there might be a genetic predisposition. There also is one for the irritable bowel syndrome. And as I mentioned, it seems that oftentimes there's a preceding gastrointestinal infection, about 2 to 3-fold increase in incidence after salmonella or E. coli infection or Giardia or norovirus or Campylobacter. Those are common kind of infectious conditions. They increase the risk of both irritable bowel syndrome and functional dyspepsia. Symptoms more common in smokers than not. Overall, it has something to do with meals, but we don't exactly know what it has to do with meals. We know that you get the fullness and the bloating. It seems to have something to do with the total number of calories and the amount of fat that you consume. So people who have functional dyspepsia oftentimes snack a lot and eat less at the meal. That seems to relieve some of the symptoms. As far as a specific kind of a food, a spice or a gluten or lactose, or maybe alcohol, or just fat. All of those might contribute, but at least as far as the studies go, when blind challenges are conducted, nothing specific in the diet seems to be at fault. Some people think it might have something to do with the food maps. Those are the fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. That's popular nowadays, along with gluten intolerance or celiac disease. Generally not an issue, actually. As far as gas is concerned, a lot of people complain of increased amount of gas. They belch, they have a sensation of abdominal pressure and bloating, and they have some gurgling in the stomach, call it borborygmi. Sometimes there's an increase in abdominal girth after a meal. Sometimes people have excessive flatus. If the flatus comes out from down below, it's probably related to irritable bowel. If it comes out from up above, it's probably related to functional dyspepsia. Large percentage of the people, as I mentioned, have some visible abdominal distension, but that doesn't mean that the abdomen is distended because there's something wrong. What's happening is that the diaphragm's contracting and the abdominal wall muscles are relaxing. And yes, indeed, that's the cause of the increase in the abdomen dimensions, the abdominal distension. Doesn't mean that there's anything specifically wrong. That's a perfectly normal variant. On prolonged follow-up of these individuals, about 15-20% persistent symptoms, about 50% symptoms seem to resolve, about 30% of the time. They seem to merge with other gastrointestinal conditions, other functional gastrointestinal conditions. Well, should we evaluate people who complain of symptoms of functional dyspepsia? And the answer is overwhelmingly no, but if a person's losing weight or if a person has the first onset of symptoms after age 55, because after all, the symptoms usually come on in the 20s and the 30s, maybe the early 40s, Well, if you happen to be over 55, yeah, let's evaluate the condition. If you have iron deficiency anemia, you're bleeding, you have a family history, a personal history of upper gut-related cancers or masses or lymph nodes that are swollen, or you have difficulty swallowing or pain while you're swallowing, yes, indeed, it needs evaluation. The differential diagnosis for functional dyspepsia is enormous. You could have the peptic ulcer disease. You could have the gastritis from the Helicobacter pylori. You could have gastroesophageal cancer. You could have gallbladder disease. You got gallbladder cancer. You might be taking a medicine that's causing the symptoms. Might be taking too much aspirin or non-steroidal anti-inflammatory drug, or iron can cause the symptoms. So can your blood pressure medicine, your calcium blockers and your ACE inhibitors. If you're taking steroids, cortisone, prednisone, that might trigger the symptoms. And we know that people who have disorders of the pancreas, or people who have inadequate flow of oxygenated blood to the intestines, people who have mesenteric ischemia, people who have Crohn's disease or liver conditions, all of those cause the same kind of symptoms. Well, as I mentioned, as far as evaluation is concerned, we check for the Helicobacter pylori and we can eliminate it. But the question is, does it really do any good? Well, it does good as far as eliminating the chance of peptic ulcers are concerned, gastric ulcers and duodenal ulcers. It reduces the chance of gastric cancer. But as far as your symptoms are concerned, doesn't help. Well, what's the cause? Do we have any idea what the real cause of this condition is, this extraordinarily common functional condition? No, it's functional. So that means we don't have any idea. Some people say, well, it's the cytokines, or it's the eosinophils that are in the esophagus, or it's anxiety, or maybe it's just excessive duodenal sensitivity of the nerves that transmit sensation up to the brain. Maybe it has to do with too much acid production. Nah, none of those seem to be important. Maybe it's diet. Well, yes, that seems to trigger the symptoms, but that's not the cause of the problem or the infection. Is it your genes? Nah, it probably has something to do with the bacteria that are present in the gut. And we probably have some imbalance of your microbiome. That probably is going to be found to be the cause of the condition if it's going to be related to the GI system at all. But as we've already established, people with these functional disorders often have fibromyalgia, and they have the chronic pain syndrome, and they have a variety of symptoms related to the bladder and elsewhere. So it's probably a systemic condition, and it probably has nothing to do with the bowels at all. If we look at people who have disordered sleep, they're more likely to have symptoms of functional dyspepsia. You sleep better, and the symptoms in the gut go away. So how's that related to gut problems? And then we have some people try to make overall association of a variety of factors that seem to underlie the functional dyspepsia. So they say, well, you have a genetically predisposed person who has an infection, altered the microbiome of the gut, and then you have some food allergies on top of it, and it changes the intestinal barrier, and then that leads to some lymphocytes infiltrating in the area, and you have an abnormality of the mast cells and the eosinophils. And on top of all of that, you have abnormal mucosal response as far as the immune response of the intestine is concerned, and all of that triggers the tissue damage. Haven't been able to find any of that. This may well just be a variation of normal that we're treating with an awful lot of medicine that probably isn't going to, and for sure isn't really helpful. So in some individual cases, doctors have found, well, there's an abnormality of the gastric motility, or there's inadequate relaxation of the stomach to the food entering it, or there's enhanced gastric sensation. So if we put a balloon in the stomach and blow it up with air, it seems that those people who have functional dyspepsia seem to have more symptoms, say, than somebody who has irritable bowel syndrome. Well, that doesn't really mean anything. So what's the way that we should approach this? We should approach this condition, and we should reassure individuals, and we should tell them to avoid stress. We should exclude the depression, because all those things seem to be very common in society too. And we know that since about 2/3 of the people have symptoms within 15 to 45 minutes of a meal, have a smaller meal, snack more often. Don't have so much fat because the fat seems to be somehow associated with problems. Maybe for some people, cut down the amount of wheat. In some individuals, it might be appropriate to try to eradicate the Helicobacter pylori, but by eradicating the Helicobacter pylori, you have to take a series of antibiotics that's going to change the intestinal microflora. So you might end up actually worse instead of better. Well, the condition's not associated with any increase in mortality. So it seems that what we ought to do is we ought to treat with the simple things like changing the size of the meal rather than to go on to a series of medicines. So what you can do is you can cut down some of the fatty foods, you can cut down the fried foods, maybe have less milk, less dairy, stay away from some gas-producing foods like wheat and pasta and bread and pastry. Watch out for some of the red meat that seems to trigger some symptoms in some individuals, probably because meat has a lot of hidden fat. But the challenge tests are all negative. So we want to reassure individuals that they don't have any organic disease. We don't have any good explanation for their condition, but we know that if they reduce the amount of stress that they're under, then they're going to do well. And we know that a placebo response seems to be as good as any medicine that's ever been tried. So people routinely are given prescriptions for the proton pump inhibitors, medicines like Nexium that you can now get over the counter, or a variety of other similar medicines. Do they do any good? Overwhelmingly, no, they really don't. Could make matters worse, especially if you take them for too long a time period, because we know that they are associated with long-term increase in side effects. Well, some people take drugs like Tagamet. We call them the H2 receptor antagonists. They actually work probably somewhat better than the proton pump inhibitors, the drugs like Nexium. But the quality of the trials is pretty low. Some people take bismuth or antacids or sulcrophate. It's not really helpful. Other people get a little fancier and they start taking busparone. It's Buspar. It's anti-anxiety medicine. Or low doses of the tricyclic antidepressants, medicines like amitriptyline. Slows the gastric emptying, supposedly, or mirtazapine. Seems like the SSRIs are of no benefit. Remember, it seems like probably we're dealing with an abnormality maybe of the gut-brain axis. But some people suggest a medicine, fortunately not available in the United States, called Neoprat. It's an antipsychotic, although it's primarily used for gut motility abnormalities. It's a prokinetic. It makes the things go through the gut a little bit more quickly. Well, actually, the American College of Gastroenterology and the Canadian Association of Gastroenterology, they say, exclude the Helicobacter pylori. There's moderate to high quality evidence for some of the PPIs, and low quality evidence for the tricyclic antidepressants, and very low quality evidence for prokinetics. And as we get more sophisticated in our medicines, the likelihood of side effects increases without a consequent increase in the benefit that you're going to get. So gabapentin and Lyrica, used for almost everything these days, no help. The opioids, no help. People take Singular, no help. Antibiotics that supposedly kill certain bacteria in the gut, again, no help. Psychotherapy, there's no good data to suggest it really is any good. Acupuncture, probably okay because it doesn't cause any harm, and some people might actually get better with acupuncture, and certainly much better than some of the medicines that have other side effects. Homeopathy, okay. Probiotics, good idea, go take some. Probably not going to help, but if you think they're going to, go take it, because it's a heck of a lot safer than our prescription medicines. Herbal supplements have been recommended, especially one called Iberogast. But Iberogast is associated, according to the German government, with liver disease, with problems with pregnancy, and actually with deaths. So that's not good. And the symptoms, we don't even know that they're really constant. Some of them come and go. They do that spontaneously without any interaction with the medicines that you're taking. So try to stay away from a variety of medicines if you have symptoms that don't seem to be terribly bothersome. And remember, the more sophisticated the medicine is, the more likely you are to have some side effects. So you want to be very careful. So in this case, with functional dyspepsia, I would tend to move more to the complementary and the alternative therapy, because that doesn't seem to be harmful. So that's acupuncture and the homeopathy and the probiotics, and go take some herbs if you want. That's the story about functional dyspepsia. And the question is, are we making a disease out of a variety of symptoms that are part of the normal process, and then trying to treat it with other kind of medicines that are associated with really real side effects? So we have to be extraordinarily careful. And that's the bottom line. As with any condition where there isn't a diagnosable abnormality, where it's just a collection of symptoms, we do have to be careful, because our medicines oftentimes do more harm than benefit. Anyway, thanks for watching. If you enjoyed the show, please consider subscribing so you'll get notices as we post new videos. Appreciate your interest. I'm Dr. Ken Landau.